Greetings all. We are live and we are with the very wonderful Dr. Angela Wright, who is a GP, menopause expert and also sexologist and member of multiple organizations that delve into the interesting things that happen with women and sex. And today we're talking about menopause and sex. So Angela, I'm just going to whiz over to this other thing and press live there. Then I'm coming back, and as we do this, a lot happens around menopause. Some women find that their sex life gets better, but the vast majority, it seems to find that their interest in sex declines. They're too hot to be touched. They're hot and flustered, and they're not really very happy about the whole process. What's going on?
I think it's like a car crash potentially of stuff that happens in the body. A lot of the underlying systems that help us to want sex, to respond to sex, they change when we go through menopause. But also it's a really big transitional period of life. I think, if it happens to you at midlife, you have a lot of other stuff going on, and you can't ignore that we are busy. We are being pulled in 1,000 directions. Most of us are knackered and distracted, which doesn't help. And then there's the kind of the wider stuff in terms of society, like how it sees aging women. Are we supposed to be sexual? Are we given images of women that look like us that help us to feel sexy? So all of that, I think, comes together at this stage, definitely, and causes problems, or potentially.
Yes, exactly. Now, one of the things that is often pointed to is testosterone, and there's a general feeling at the moment that testosterone is the answer to everything. If you're on testosterone, you'll be swinging from the chandeliers, having the best sex of your life. You'll be solving Sudoku puzzles simultaneously and running marathons. How much does low testosterone contribute to libido, and is it the answer that we're all looking for?
I mean, the short answer to that is, if it was only testosterone, I wouldn't see anybody in their 20s and 30s and 40s who would be having problems with sex and libido. And that just isn't the case, because it is that interplay. There are definitely women for whom the loss of testosterone directly or indirectly is part of the problem. It's maybe the biggest jigsaw puzzle piece for that person. But in my clinic, I probably give out more testosterone than the average menopause doctor. I am not mega impressed with it as a clinician as being the thing for most of the women. I'd never withhold it. I always let women try it, because that's, the best. And if you've got something that helps, then God, why wouldn't we use it? But for a lot of women, it's just not as simple as that.
Oh, okay. When you say you're sort of handing it out quite well and giving people a trial, what are they coming back and saying? Because I think the studies basically show that it works for around about 60% or so of people, and a vast number of them find that they don't notice any difference. Is that what you're finding too? That they come back after 6 months, it just didn't change?
I mean, I suppose for me, I'm doing a pretty in-depth assessment. I'm asking a lot of questions to understand, like, the nuance of what do you mean when you're saying that libido is lost. Because we don't have a very good language to describe what's happening a lot of the time sexually. So the final common pathway, whether it's pain, fatigue, depression, bleeding, lack of orgasm, lack of arousal, dryness, is you don't want to have sex. So most people show up and say, my libido is down, but it can be way more complicated than that. But probably about those figures, actually, I would say maybe 50-60% of my patients stay on it. I get a lot of people that find that it makes a difference in stuff that it's not supposed to make a difference with. So their energy, their mental clarity, and that indirectly makes them feel more competent, more on top of things, more sexy. I think there's an element of feeling like, if you feel like you've got your life in order and you feel like yourself, it's a nicer place to be, and it does us often unlock something, even indirectly. But yeah, some people, in my experience, women who don't get on with it, they just stop it. So I sometimes wonder why we gatekeep quite so much, when I've had very few problems with patients on testosterone. I've hardly had anyone that I can think of that's had a worrying side effect from going on to it. And women tend to just stop if it doesn't help.
Yeah, it's an interesting one, actually, because I've just had to stop. I've been on testosterone, I think, probably about 7 or so years, and my hair started falling out.
Yeah,
like a lot of hair started falling out, and I started to grow, which was what was actually literally the equivalent of, remember when Robert Downey Jr. had a goatee?
Goatee.
I use both. I mean, I've got the moustache and the goatee. Strangely enough, not the mutton chops, but literally this section was just insane. It's starting to come down now. But in all honesty, I noticed no difference in
Yeah.
stopping at all.
Yeah.
Which is kind of interesting because I was expecting that I would find, no difference. But the other interesting thing that it was actually Jen Gunter raised it the other day in her Substack, I think, and she was talking about it. You were talking about indirect benefits of testosterone, and I didn't know that testosterone was involved in iron metabolism. And so basically, she was saying, perhaps the reason why people feel that they've got more energy and they're less tired is because indirectly the testosterone might be affecting their iron levels. There's a thought.
I mean, it's when I work in men's health and we use testosterone in that setting, there's a lot of evidence that looks at men's bodies with testosterone, and they say it's a pleiotropic hormone, which means that it has an impact on all sorts of different systems in the body. And it's really likely that the same thing is happening in female bodies, but we just don't have lots of research that helps us to understand the nuance of all of it. And also we know that there's different levels of sensitivity to your own hormones. So there are variations in the receptors, the codes in your body for the receptors, which means some of us are really sensitive to the presence of testosterone, others less so. So I think that's what you see in women. You see women who really campaign for access for testosterone because for them it was like the missing link that made a difference. Other women, it doesn't have a huge impact on. Some women can't tolerate much without having hair loss or skin changes. Other women, seemingly feel fine even when their bloods come back and they're a little bit over the level that they should be. So there's all that complexity. And that's only when you're looking at, this hormone as being the thing that's got in the way of sex. And it often, it's rare that it's just that one thing.
Yeah. You mentioned in there physical changes, and this is stuff that we don't really talk about all that much, really. It's sort of, the shrinking clitoris, the dryness, all of those sorts of things that might decrease sensitivity in sex. Is there anything that people can do about that to get those sorts of things back?
Yeah, so this is about blood flow. Part of it is blood flow into the tissues. Part of it is hormonal. Part of it is just the passage of time and age. And we don't often think about our tissues as being that similar to men's genitals, but actually the structures, the erectile tissue structures are really, really similar. Even in volume, they extend a long way into the vaginas. So we've got all this erectile tissue that when you're young and you're healthy, at nighttime is being flushed through with blood, like nighttime erections, morning erections, and it keeps the tissues healthy. It keeps the volume of the tissues there. And quietly, we often lose that. And some of that is diabetes, heart disease. Some of it is the drugs we take, just general metabolic aging. Some of that is our estrogen and our testosterone. So we go off, it kind of goes off a cliff at this stage if you do nothing about it. Again, it's not as studied as male bodies are studied. We do a lot of work with male erections because they're right there and they're visible. And when they go away, everybody worries about sex. But with women have been quiet during joyless sex for centuries. We've put up with it, but the same process is going on. Hormones are really quite important, local ones. It doesn't have to be systemic HRT necessarily, but local vaginal estrogen. There is some evidence around androgens for clitoral volume and blood flow, and various parts of the vulva are more sensitive to testosterone than they are to estrogen. And there are some products, as Intrarosa, that provides both of those hormones. So again, it's about, for me, it's about the questions about, have you lost arousal? Have you lost sensitivity? What is it that's changed? And if you focus on that, that's how you make it better.
Which is an interesting thought because, there are a lot of people like, say like me again, study of one, who is on HRT, but I also have an E-string or S-string, or depending on how you want to pronounce it, plus the cream for the external area. But is there a point then, perhaps say, like if sensitivity were my issue, that it would be better to swap the estrogen for the DHEA, or can you have both at once? If you've got one thing to have dryness, another thing to have decreased sensitivity, can you mix and match these things?
So you can, but it's off-label. And again, you've got this debate in you wrote a book on it. You've got this debate all the time between professionals that are going, stick to the evidence, and people saying, yes, but we don't have much evidence. And in my practice, yes, I layer things up. Again, we know that some women don't need much and things get better. Other women seemingly don't respond to licensed doses of products. DHEA in intrarosa is relatively weaker in its estrogenic activity than some other forms of estrogen. So you have to kind of weigh that up if you make a switch, but it's definitely worth a go. I mean, in my own treatment, I would use more than one thing if, to sort of solve the problem. And what I do for other patients is exactly the same. If they need to layer up two products in order to get access to the DHEA aspect of things, as well as the vaginal estrogen, you've just got to explain to them it's off label and make sure that you are, being cautious about other health issues that are going on. But these are tiny doses. These products are barely absorbed into the bloodstream. They are so much less impactful than a decision to give, 1 pump of estrogen or 2 pumps in gel systemically. That's a bigger decision. This is a tiny decision.
Yeah. You mentioned also in there other causes for not particularly being interested in sex, and pain is one of them. And as you know, because you helped me with the questions, the Menopause Research and Education Fund has just done a survey of more than 500 women. And without preempting too much of what is in there, there were some pretty scary and interesting results. And that was that, literally around about 3/4 of women were experiencing pain with sex in perimenopause or postmenopause. About 1/4 of them hadn't had sex in more than a year because of it. And here, when I'm talking about sex, I'm talking about penetrative sex. That doesn't necessarily have to be with the penis. It can be with the device. And another quite large swathe, around about, I can't remember now, but close to around about 30% or so, were saying that, yes, they were still having sex despite the fact that it was painful. So there are a number of things to unpack there. First up, I guess, is what is causing that pain? And then the second one is, and we'll get to it, the reasons for why they continue to have sex then. So let's start with what could be causing that pain, apart from vaginal dryness, because we all just go, it's all vaginal dryness, have some estrogen, you'll be fine. What else is there?
So, I mean, I suppose there still is vaginal dryness. You're on treatment, but you're not on enough. I get a lot of people that are on stuff but still dry. So that's there. There's lack of stretch in the tissues. So over time, maybe post-cancer, various treatments that people have, the tissues can get less stretchy. So you can actually have an issue with the amount of room that's in there. You've got a demographic of women who might have fibroids or might have a bulky uterus. That means that can be uncomfortable. There can be endometriosis, adenomyosis, and so on, that's still causing an issue in terms of discomfort. There's the changes that happen as you go into menopause, create tissue changes and reduce arousal. And arousal gives you more space in the vagina. So when you have sex and you're fully aroused, the uterus lifts up, the vagina opens inside, and we make space. So if we're less aroused because we're getting less input, we're distracted, we're worried about, other stuff, your mum falling over or whatever, and you've got that on your head, then that's a problem. You've also got the muscles, the pelvic floor muscles that sit like a sling at the bottom of the pelvis, and they do a really good job of protecting us from pain. And they kind of sometimes hold a no or an I'm not sure, even when you're going, oh God, I better do it. I haven't done it for a month. It's going to be a problem, and you're saying yes. Your body will still be kind of slightly protecting you by holding tension. So vaginismus, which is the official sort of name for that, can really complicate when you've had remembered pain. So there's all sorts of pictures that can be part of this.
Yeah, absolutely. Now, you mentioned there the still having it while they were having pain again. And in the survey, a whole bunch of people came back and said that, yes, it was they were still continuing to have sex, because it was just, it was important to their relationship, it was important to them. But there were a swathe as well who said, I'm really worried that if I don't have sex, even though it's painful, my partner will leave me. A couple said it's cost me my marriage. And I remember actually one of the main reasons, it gives me goosebumps when I think about this. One of the things that, one of the main reasons why I wanted to do this survey was a woman ages ago who, in my much neglected vagina and vulva private group, said, I don't know what to do because, basically help me. I don't know what to do. My husband says he's going to divorce me if I don't have sex with me. And he does, because he doesn't believe it's painful for me. And there are a number of women who also answered the same way in this survey. So How do we get this across to men? How do we carry this through? I mean, I guess, how do these poor people get rid of their pain, and how do we carry it through so men actually really do understand this?
God, that is a massive question. So one of the things that got me into doing this in the first place was that stat, actually, even about younger women, that even though people experience pain, they continued to have sex. It's not just menopausal women, it's a woman thing. We're focusing on heterosexual sex, but it's not going to be just I have same-sex couples where the dynamic is a real challenge because one of them doesn't want to have sex and the other one does. And it is something that comes up all the time in clinic. In fact, to be honest, most of the time I'm almost treating someone outside the room, or that's initially how it comes, that someone says, I don't care if I never have sex again. I've lost my interest. I feel dead from the waist down. But, often it's my husband's really lovely. He doesn't put pressure on me, but. And I think, we have this issue with motivations for having sex. And, one of our motivations for having sex might be pleasure and enjoyment and what we get from it. But there are a lot of other reasons we have sex, and sex is often mate guarding. We worry about relationship breakdown if we don't have sex. We also have, I suppose it's not always the case, but often for male partners, it legitimizes comfort. I want you. I can be held. I can be close. I've had a bad day. I want to feel connected. We don't necessarily in our society make it easy for guys to say I want to cuddle as much as perhaps we would want to. So there's often a real mismatch in the message that's being received, where a female partner's going, I don't even recognize what's happening with myself. I've got a lot going on. This hurts. I don't feel sexy. I don't want to look at any of it, and I'm just blocked. I can't even go there. And a male partner is often feeling quite rejected and isolated and not necessarily sure that it's ever going to end. They've got lots of messages about what masculinity looks like. So it's just this complex mess. And I think, if I like that, getting on a soapbox, for centuries, women have been raised to be compliant and to feel that men will explode if they don't get to have sex occasionally, that kind of blue balls theory that I think we get indoctrinated in. So I think all of that stuff plays into it, and what works is communicating. If you can get, what I often do with couples is try to sort of help them with communication, which is making sure that the person's getting the correct message. So that one that says, he doesn't believe me, you've got to get underneath that and maybe share a podcast or a video that sort of gives some factual information. Maybe get across the message that it's not always going to be like this. Bear with me. I'm trying to figure it out. I said to someone the other day, if someone comes after you all the time with food and constantly, like we're about to go into Christmas week, most people by about 3 days in don't want to even look at another chocolate biscuit or another snack because someone is bringing you something constantly. And a lot of women are so aware of partner's needs, partner asking, partner initiating, they lose any connection to their own hunger and desire because they're just trying to guard this space, so sorting that dynamic out is incredibly important.
Yeah, absolutely. And the other group, there's a question over here is one, and it is a very, very important one. The other group who obviously suffers through incredible amounts of pain with sex are people who are on aromatase inhibitors and have estrogen positive cancers and all of those sorts of things. And there's a lot of debate about what they can and what they can't have. Where do we think we stand now in this ever shifting landscape of estrogen and cancers?
So I would put my stall out and say I very firmly stand in the fact that this is so impactful for a woman that the person that should be making a final decision on whether she has estrogen or not locally or progesterone is that woman. And again, I think misogyny within medicine, doctors come from the societies that we all live in. We're not sort of trained to think about female pleasure, to consider sex as important to women, to think about urinary issues as being estrogen related. All of that needs putting into the potential benefits. On the other side, you've got this little bit of possible risk, mainly because of an absence of data. We don't have much data to suggest it's unsafe to be on vaginal estrogens and progesterone if you've got an aromatase inhibitor as part of your cancer treatment, but we don't have acres of safety data for that specific drug. but we do have lots of consensus statements from all parts of the world that say, so an American, an Australian, and the St. Gallen Statement, all of which say that if a woman understands the risks and benefits and wishes to have it, we should support her in having access to low dose estrogens if nothing else has worked well for her. So that kind of informs my practice. We have some hesitancy in some parts of the UK still. So that's the challenge. Yeah.
And there are a couple of quite rare cancers, are there, where we basically say no?
One or two where we don't. But again, that's still largely based on absence of evidence or poor quality evidence rather than a really solid evidence base. So, I mean, I do unusual work. I work specifically with menopause and sex and often post-cancer. So I probably see and do a little bit more than this than the average person, and GPs are quite rightly going to be cautious on this subject, but there can be a little bit more wriggle room than originally, than you may think in some of these things once you get into an in-depth discussion with oncologists, because often the data that underpins some of those things is not actually very solid. And we know, I guess the key point to say in something like this is what we do know is that these products don't absorb into the bloodstream in any large quantity. So that's where this comes from, this idea of actually when we go and check a woman's levels for estrogen when she's on one of these products, we see very small rises in terms of picomoles, if we see anything at all. It's single figure rises in picomoles. So it's individual. It has to be gauged against her cancer, the stage, the impact of hormone deprivation, yada yada yada. But her choice is important in there as well, in my view, because what's the point of being alive if you have no quality of life? And we sometimes get a bit paternalistic about this as doctors, I think. I'll tell you my patient that I had, who was an aromatase inhibitor user, who was given signed off by her doctor to jump out of a plane, and she wasn't signed off to use vaginal estrogen on an aromatase inhibitor. So I kind of think sometimes we hold these ridiculous concepts of risk for our patients, in my view.
Yeah, exactly, especially given, I don't know if you saw it the other day, the video of the guy who jumped out of the plane and his parachute caught on the back of the back of the plane, and he had to cut it off and then hope that the other one opened. And I'm thinking, there are some things in life I'm really just not going to do, and that's one of them.
And the party line at the moment is being held, like the BMS party line in the most recent consensus statement is being held quite cautiously. It's just, try non-hormonal things first, then get into a conversation with your oncologist. I think some of us fear that for women who are 10 years, 15 years past their cancer treatment, the odds of there being an oncologist that's going to get involved in that conversation are quite low. And that might be a barrier to her accessing treatment when it actually might be an appropriate thing for her. But broadly speaking, you talk to the woman, you talk to the oncologist, and you make a decision that's informed by her choices.
Well, exactly, especially if it means that compliance is going to waver. If you're going to stop taking your drug because
it can be miserable drugs.
Yeah, exactly. I mean, it can literally get to the point where you can't sit, you can't walk properly, let alone thinking about even having sex. If you're at that point and you're thinking, well, I can't take that anymore, when you could solve it by having this, it would be very self-defeating not to.
And I mean, I do workshops every couple of weeks with women who are post-cancer, as part of voluntary work or whatever. And you see rooms of women who are absolutely in bits over this aspect of their life and their relationship, whether they're in stage 4 and they're facing potentially shortened life expectancy, or whether they have got a chance of, curative treatment. They are scared and isolated and struggling with their relationship, trying to pick up the pieces. And we are gatekeeping, I think, excessively something which has got not no risk, but lots of the data suggests it's very, very low risk and really good benefits for people. So I just think sometimes we have to sort of look at the entire woman, not just her breast cancer risk.
Yeah, yep, exactly. And with the gatekeeping, one of the things that the study also showed was that literally only 5% of respondents said that they had a positive experience with their GP when they went to talk about vaginal issues, which is fairly scary. And the same things came out. Literally the lie back and think of England, fake it till you make it, have a glass of wine, all these sorts of comments that just sort of, just
not even medical.
Fine. Yeah, so this is another. How do we overcome that? I don't think I know what I'd say if somebody actually said that to me. I think I'd probably be so shocked I wouldn't actually have anything to say. I'd be like,
Happens
what?
a lot, and unfortunately I get these people that end up sat in front of me eventually when they get referred in on the NHS, and they've often been told, think of something else, have a glass of wine, well, should you still be having sex at your age, this is normal, and all sorts of things.
Why do you need a libido if you're single?
Yeah, absolutely. Exactly. So that there isn't any training, that's the reality of it. Until I did my specific training, I could write down what I'd learned about sexual function beyond Viagra on the back of a little mat. I just didn't get any adequate teaching. We're British. We're not very good at talking about sex. So most of us in our own lives, we might talk jokingly about sex and we banter around it, and it's in all the magazine articles, but in terms of actually vulnerably talking about it, we're not very good. So people feel awkward in conversation, I think, as well. And we certainly don't teach that something like vaginal dryness, well, it's not just vaginal dryness, we don't teach about asking about all of the elements of genitourinary syndrome of menopause, and the fact that this is a cheap, easily treated condition. Once we use the medication, you can use it lifelong, and virtually all women, I would say, would probably benefit from vulval vaginal estrogens postmenopausally. It's hard for me to think of a circumstance, except there's isolated hormone sensitive cancers where risk may be considered too high, that wouldn't benefit from improving the health of their genitals and their bladder. The bladder's involved in all of this, and we get so much urinary sepsis, so many hospital admissions from UTIs, But yeah, it's the answer to most of this, Fiona, is it's misogyny. It's baked in. We didn't have female doctors until about 120 years ago. We don't research on women. We don't talk to women.
No, and we need to do that much more. Actually, there's Lucy, a family lawyer over here, is saying that the communication is a huge issue with men as well. And as we also found in that survey, there were a lot of cultural and socioeconomic differences as well, with basically sort of white middle class women doing quite well at the discussions with their partners and feeling relatively well supported, but other lower socioeconomic groups or different ethnic groups not feeling quite as well supported, or not getting the treatments either. Basically, unless you're white, well-educated, or Indian and well-educated, you really didn't get much of a look in, which is a bit of a shame.
Those intersections are across menopause care, they're across healthcare, full stop, whether your disability status, neurodivergence, educational status, socioeconomic status, all of that, and that's absolutely what we're seeing playing out. It's not an even playing field out there at all.
No, it really isn't an even playing field at all. The other things that people say can help are the use of devices such as vibrators and those kinds of things. Now, one thing that really, really pisses me off, as you may have noticed from my outline of questions, is the claim that if you use a vibrator, you won't end up getting genitourinary syndrome of menopause. And I'll tell you the reason why that really pisses me off is because the claim comes out of a study that was done, I can't remember, about 20 years or so ago, that found that people who had more sex had less genitourinary syndrome of menopause symptoms. So therefore, they extrapolated from that if you kept on having sex, then you wouldn't develop these symptoms, because obviously, it was improving blood flow and doing all of those kinds of things to the area, and therefore you were better off. Well, again, the study of one, I can absolutely guarantee you that my vagina did have its reasonable amount of sex, and my genitourinary syndrome of menopause was not pleasant. So
the study is nonsense anyway, because they did, the people that were having more sex were probably having more sex because they were having less problems with having sex. And this crept into the most recent update of the BMS guidelines, the British Menopause Society guidelines for genitourinary syndrome of menopause came out fairly recently, and there's just a little hidden line saying that continuing to have sexual activity can be helpful. And again, what I see play out in clinic is that happens a lot, that women think it's use it or lose it. It contributes to continuing to have joyless, painful sex, which only reinforces aversion to sex and your body clamping up and all of those kind of blockers. What is true, I mean, I've got a desk full of toys out of shot here. I've got hundreds of the blooming things, and What is true about toys is they can be like a hearing aid for your vagina. They can amplify, or vulva, they can amplify sensation. They can bring novelty. There is evidence that if we use vibratory massage, that it improves vulval pain conditions. I think 76 or 78% of women found that their vulval pain got better when they massaged every day. There's some tentative evidence that getting blood supply into the tissue through vibration helps to improve tissue quality, and can actually, there's some evidence around pelvic floor muscles realigning. So with caveats, I've had a woman who was masturbating daily, gritted teeth, feeling ridiculous, not wanting to, because she thought she had to. So if it's acceptable to you, if you want to, if it's easy enough for you to do your vulval massage once a day and use, you know, like I've got a simple pebble vibrator, something like that on your vulva, great. I recommend it frequently. Do not have sex you don't want to have. Do not have solo sex that you don't want to have. This is a really, wanting is such an important thing, and we can really get in the way of wanting when we do lots of should haves, must, and it is for someone else, and it doesn't fit our identity or you know where we're at. And I really, really hate use it or lose it. I think it's really
that's what somebody here has actually just said. It's the old use it or lose it argument.
I hate it.
And it is, and it just drives me batty. It really does every time I see it popping up, and it always pops up in studies that are done by people who sell vibrators. So
this is the challenge, and we make sex this again. It's that kind of internalized misogyny thing of, don't you want to be a sexy person? Don't you want to continue to be sexually active at this stage? I mean, what is your worth if you're not? And there's that pressure on all of this area as well. So I think it's super important that you stick the woman in the middle of all of it, and you find out what the hell she wants to happen with her body at this stage, and you build it around her. Wouldn't that be nice?
It would be nice. And there were some who were saying they were having better sex than they'd ever had before, for a variety of reasons, which is nice. It's,
I see that. I see people that. Yeah, and people, you know, midlife women are often, they get quite a lot of surges where they're interested in sex. The infidelity rate rises in midlife women, and that's possibly because they want sex, but not necessarily the sex that's available to them. You know, there's all these other social constraints and issues that are part of the picture. So we've got to be really careful when we talk about this stuff. It's very individual.
Absolutely. Question over here. Would tadalafil 5 milligrams, do you think, off license? So
lovely question. Yeah. So there
is this what's just been approved in the US?
No, so ADI is different. That's flibanserin. So tadalafil 5 milligrams is a phosphodiesterase 5 inhibitor. It's from the same group of drugs as Viagra. They were originally trying to use Viagra as a heart drug, and then all the men in the trial got erections and didn't want to give it back, and it kind of became a sex drug instead. Again, we have the same anatomy, we have the same erectile tissue, we're losing our nighttime erections. There is a study, systematic review, I think it's about 5 or 6 years, no, it was 2014, I think. About 14 studies were done, mainly in premenopausal women, people with diabetes and heart disease, showing that it does seem to improve arousal and therefore improve sexual function. Also improves clitoral blood flow on Doppler studies. I use it for patients. I select them. It's not, again, it's about what is going on in your body. Have you lost that sensation of genital fullness? Does it feel like you don't get as much blood in there as you got before? Has your sensation dropped? Does it make sense that that might be what's needed? Sometimes 5 is too much for menopausal women. It can make them flush more because it opens all the blood vessels everywhere. So sometimes I just give them 2.5, and I give them 3 months, 6 months. If it helps, it can stay there. If it doesn't, we can stop it. But yeah, it's and there's trials being done on these drugs. They potentially will be more available in future, specifically for women. That might be 10 years down the track. Flibanserin is just been approved by the FDA, and it works in a different way. The idea there is it kind of improves some of the brain neurotransmitters that might make you want sex a bit more. And again, there's that kind of, you've got to pick the person. There's quite an ethical thing that goes on there about making sure that the person that's being treated is the person that wants their sex drive back. I think we've always got to be careful about power play and stuff in society with these things.
Yeah, yes, we really do, don't we? Intimacy, that's the other thing. But actually, before I get to intimacy, let me throw other physical changes, like prolapses and leakage, and because you mentioned bladders and things before, how much do they impact on our ability to actually have a reasonable sex life?
Can do. I mean, there's some studies that show that the stretch in the tissues that happens with that can also be part of diminishing sensation. So there can be that kind of, the wiring can be affected. You've got anatomic issues in terms of, can you get past how prolapses vary in grade and severity, but for some people they can work well around it, but for other people it can cause a bit of an anatomical issue. It's body image issues that go with that. It depends on the individual and the relationship and so on, but for some women it could be really inhibiting. And again, it's often speaks of laxity in pelvic floor, and pelvic floor muscles are your orgasm strength. So the strength of those muscles for those contractions is quite important for the sort of all the effort of sex. And if you finally get to climax, you don't want it to be a sort of you want to have some kind of power behind it. So pelvic floor muscles can be part of that picture. Another thing is other parts of the body. So I think, we've got this very genital centered focus on what people are doing sexually, but I get loads of women that tell me that they don't get sensation in their nipples anymore, or that breast play was a really important part of how they express themselves. And that was always a really key part of foreplay, and that can change. And again, it's about sort of, I suppose it's broadening. Can you not get into a certain position anymore? Is your mouth dry and you can't manage, with kissing or oral sex, and because you're on treatments for other things? And there's lots of other bits of expression that can be impacted with age and hormone loss.
Absolutely. And if we're at that point, then when we're thinking, okay, sex isn't really working for me at the moment, intimacy, is that there's nothing wrong. What are nice ways of keeping a relationship sort of relatively intimate if we're not necessarily actually having what would be regarded as traditional sex?
So I would bust the definition of traditional sex really early. A lot of what I have to do with patients is to say to them, actually, let's take the word sex off the agenda and let's just think about pleasure as being the thing that we're sort of focused on. What pleasurable things do you like happening with your body, to your body? What do you like giving in terms of pleasure to a partner? Actually, often we take penetration off the agenda when we're doing sex therapy and say for 3 months or 6 months, you are not having penetrative sex. And that's because I hear it over and over again that we just get used to, in relationships, we know that, I don't know, if someone slaps your ass when you're loading the dishwasher and you get like a cheeky wink at this time, the kind of the steps that mean that sex is on the cards. And what happens is, relationships, nobody wants the conflict, so people shrink away further and further from any of the situations that previously would have been a green light. So the loneliness and the isolation is much, much greater than it needs to be, because everyone's worried that if they say yes to the date night or they go to bed at the same time, that there's going to be an initiation and they're going to feel awkward and the partner's going to feel rejected. So talking about it is really important, because when you say to somebody, I miss talking I statements, I miss how close we were, I miss lying with you afterwards, I miss how relaxed and easy it used to be at a different point. And then you start to negotiate, well, what do you still have available to you if we're not going to focus everything that we do on this one thing? Post-cancer, that's really important. It's like, you may have, I often think it's like we were running on petrol before and now we run on diesel. Like the way we used to feel desire may have had more of a spontaneous element to it when we're in our fertile years, and more hormonal. It's like a hunger element, at least in the middle of the month. When you're postmenopausal, if you're not using all of the hormones, you sometimes have to get into that, I didn't know I wanted to eat, but then I smelt the bread baking in the oven and I felt hungry. And you have to kind of put yourself in situations where you might feel arousal in your body that flickers a bit of appetite, and then if you've got no good reason not to, you might actually have some form of intimacy. So talking about it really helps to state intention. It can help to say, I want to get back to touching, and I'm so worried that every time we do this you're going to want penetrative sex that I'm not even letting us touch. Can we just hang that for 3 months and just try and get back to, twice a week I might give you a massage and some touch, Karen Gurney always says, stop sex from being a 3-course meal. Think of it as a buffet. Do I just want a breadstick tonight, or am I going for the entire bloody smorgasbord? It's like, it's okay to it's okay to have like a tiny snack. It's okay to spend 10 minutes kissing and just really enjoy that. But it's okay to do all the other stuff as well. And because the focus is often on what you can't do, or grief for what you've lost, and it doesn't look like it did, so you don't want to go there because it makes you feel bad. I often say to couples, you're doing nothing. I could get you to physically have sex tomorrow, but you're not doing it. And that's not about your body. That's about your mind, the loss, the awkwardness, so it's, all that stuff.
Yeah, and it's so difficult as well when you've got all of this stress, because you mentioned before about being, the sandwich generation, and because I mean, I don't know, but I mean, most people would probably find when they go on holidays, if they're lucky enough to go on a holiday, that they have way more sex than they've had probably throughout the entire year. So I mean, getting around that? How do we actually just sort of living? How do we cope with living?
You know how that happens on holiday. It's because you come out of your head and into your body. You've got the context and the expectation that this is a time that you're going to spend more time together. You're more emotionally connected. You may be having a drink and you're having a conversation. External distraction goes away. You are more in your body. You are noticing the sun on your skin. You're noticing the sand, the waves, or wherever you are. You're in your body with sensation, which is mindfulness. So you're more connected to sensations. And I suppose some of it is thinking about what are the conditions where I'm most likely to be arousable. What do I do that turns me on? What do I do that turns me off? And I don't mean sexually. I mean, yesterday I was super busy and felt overwhelmed because I had lots of deadlines, and I was very closed down and stressed. Today I've exercised, things are slower, I'm more in my flow. And it's knowing those things about you, because I increasingly think sex for a lot of women is a bit of a Maslow's hierarchy thing. You've got to attend to your basic physiological needs. You've got to feel safe. You've got to feel connected. You've got to have a body image and stuff in place first. And then it sits there when everything else is okay, then we can do stuff that's about connection and creativity. But if you're fundamentally distracted by the fact that you don't feel good in your body, you feel disconnected to a partner, trauma is really prevalent at this age in terms of coming up for people, triggering for people. It's a big transition in our lives, big developmental stage, or post-cancer, lots of trauma, and all those hands on your body, all those things that you've withstood. It's different for everybody, but you want to get to the point. I sometimes say, because I've got animals, you want to get so that your body, your nervous system feels like the happy cat in front of the fire. You want to be that stretched out, languid version of yourself where you wouldn't mind a tummy tickle. And most of us are the dog with the hackles up because the postman's walked outside. We are just jumping on emergency mode the whole bloody time, wondering which plate we're going to drop and who's going to phone and say they've fallen over. And anything that gets you into happy cat is good for sex. So whatever that looks like for someone.
Yeah, absolutely. That's a difficult one. And this is a little bit left of field, but just because, body image, this is the other thing. And that, I know this was a really big, difficult one for me. I'd gained weight and everything's going south, and you just think, I don't feel sexy anymore. But have you noticed that? Because, over the last couple of decades, we have become a much larger community. I was looking at some obesity figures today since the 80s. It was two very good slides of what the pink bit was what we were in the 1980s, and it grew like this to what we are now. Have you noticed that there are more of these issues as our circumference has increased, so to speak?
So if you look at it purely biologically, as we gain weight, our cardiovascular systems and hormone systems get slightly less good anyway, even without menopause. So we see more sexual dysfunction associated with obesity. But that's different to body image. And actually, body image is not so much BMI related always. It's often more about body positivity, the shape and tone of our bodies. There's a lot of stuff that gets into that. What we know from the way that women think about their bodies is we tend to objectify ourselves and deconstruct ourselves. So we will say, my hair's okay, but I hate my eyes, I don't like my boobs, my bum's all right, and we break ourselves down into pieces and tend to be very self-critical. If you look at partners, they will be much more positive about than you are. If you look at men tend to look at themselves as a whole and sort of look at themselves in the mirror and go, yeah, not bad, and just see themselves as one human that's doing all right. And so I often point out again in to the people that I work with, actually, that a lot of what's in our head is not the truth of what's happening in the bedroom or in the mind of the person that we're sleeping with. Often that person really wants to sleep with us. It's us not finding ourselves shaggable that's the biggest problem a lot of the time. And that is often to do with what we let in from the world around us. We are absolutely targeted. As soon as I hit 40, I was encouraged to be worried about things I'd never worried about before. You know, whether my hair was going to fall out, whether my boobs were going to go south, whether I needed better skincare. I often encourage people in therapeutic work to think about the messages that they're receiving, whether who is served by those messages. And flippantly, I will say that every year I go to a sex conference as part of my training. Every year we look at what is hot in pornography, and every year the top 5 includes mature women and MILF. You know, so although it's really, yeah, and then that's pornography, and they're terrible terms and everything else, and you know, but in the reality of what people do in their bedrooms, what's arousing, is not what we think it is from what we see in social. There's, you know, ultimately most of the people I work with are vulnerable people wanting to be seen and accepted by another vulnerable person. You know, they might say they wouldn't mind shagging, you know, Margot Robbie or whatever, but it doesn't mean that it just doesn't play out like that in relationships. And I think sometimes we as women we forget that. We get very focused on how we're changing. We get encouraged to see those changes as a problem, and, you know, not to think with compassion about our bodies. And we're in flux our entire adult lives as women. We're constantly subjected to change, and we're not encouraged to be gentle with ourselves in this transition. Often I say to people in workshops, imagine you were given someone else's body to look after for 6 months. How would you talk to it? How would you treat it? You know, what would you think about it? How does that differ from what you're doing with your own right now? Why?
Yeah, yes, yeah, exactly. It would be very, very different. It's interesting actually because I kind of worry with the whole sort of rise of Ozempic and Mounjaro, and there's the sort of, you know, this sort of fight to be sort of skinny again in this in that don't necessarily need it. That we may well see more people sort of body shaming themselves, and again as they their body positivity may decrease. And it's actually the other interesting thing. My husband has started Mounjaro, and I've actually lost 4 or 5 kilos as a result of him starting it. Yeah, because we're not eating the same, you know, we're not sitting down before dinner and sucking down half a packet of cashews and a block of cheese after dinner and, you know, God only knows what else. It's not that we actually ate badly, but we just ate too much. But he said the other day, and I didn't realize how unhappy he was within his own body as well. He just felt so much better within himself in terms of
important.
Yeah.
We don't talk about partner health when we're talking about this subject. We don't talk about, you know, in heterosexual couples, ED, changes in, you know, ejaculation, really common in midlife men. We don't talk about the fact that it's not just women that have this sell by date, that we all sort of feel that we've got. Male bodies age, they're less sensitive, their sexual function decreases. Like, if you want to have sex through an entire lifespan, you need to communicate and adapt. And that's the bottom line of it. And you need to be conscious about, you know, where hormones come into that. But this is not just a woman thing. And I think women feel sometimes that we are the problem that needs fixing, but it is much more complicated than that, in my view.
Yeah, yeah. What was that film where they took their clothes off? The one that was set up north. What was it called? For you.
Oh, the Calendar Girls.
No, the men.
Full Monty.
Full Monty. How could I not remember that, for God's sake? The Full Monty. Yeah, and I think one of that actually really that even way back then, that film touched on that concept of men not being all that happy in their own bodies and the way they looked as well, and feeling unsexy because they didn't feel that they were what they were like 20 years ago. So
I think that underneath bravado and the stuff we're meant to say and the things we say in the pub, I mean, I do men's work with male sexual function. Men are just as vulnerable and uncertain, you know, about this subject as we are. And I just don't think any of us are taught how to speak about it. We don't have the language for it. We're frightened of being not wanted and being left, and it's really frightening when something changes within us. But communication is, it is such an important part, and sometimes you do need to see a therapist to try and get the message out that you intend to a partner. Sometimes does require, a triangulating it, because we can just be a mess of our own defenses and our own fears, and it just goes wrong. But when you can sort of pierce that bubble of shame that sometimes sits there for both of you and actually kind of connect it with the here and now, it can be really beautiful work. And people just transition to a different kind of sex. It's not the, hanging from the chandeliers, energetic, easy stuff. Yeah, exactly. It's one of my colleagues says, when you're in your 20s, you're like a microwave oven, being you ready. When you're in your 30s, you're like a conventional oven, takes half an hour to get you in the zone. Menopause onwards, it's like an Arga. It just is it's a different machine.
Absolutely. There you go. Brilliant. All right. I think that's a perfect place to end. This is something else that you think that we haven't we have not unturned. Clitoris we have not mentioned.
I don't think so. I think that's covered pretty much everything. And I think that idea of Arga, like, the turn it off, as soon as the last orgasm's happened, you are connecting and ready for the other. So you're keeping that little thread of communication going, looking at it in that way. It's an energy within a relationship. It's not that the studies show that it isn't the type of sex you have, it's presence. That's the thing that makes for good sex. It's being able to show up and actually be there and be in connection. That's what we love. Not about orgasms, really.
Yeah, true. Although
they're nice. Yeah, I'm sat here fiddling with a toy as I talk to you.
So you're waving around them, yeah. Excellent. Brilliant. All right. Look, thank you so much for that. If people need to find you or want to find you or find out more or whatever it is, where do they find you, my possum?
I work in two places mainly. I'm on Spice Care Health, which is online, and I'm with Miss Claire Mellon and Associates at the Portland in London and Wilmslow Hospital in Cheshire, and that's online and face-to-face.
Brilliant. All right. We shall end it here, and I will speak to you soon.
Thank you.